Catherine, thank you very much, and thank you everyone for joining today. Just on slide 2 here, wanted to spend just a minute talking about some of the things that BCG has been doing as a result of healthcare reform and our commitment to enabling a value-based transformation of the healthcare system. Been making a number of significant investments around how the market will evolve, some of the new care models, and as we talk about today, some of our work with regard to new payment models, network designs, and collaborations to help support that. So as it relates to today's discussion on narrow, skinny, tiered networks, what's interesting here is you'll see that there has been an exponential growth in the interest around this topic. The number of media references alone since in the last 3 years has grown substantially, with nearly 1,000 references to the idea of narrow networks since ACA. You compare that to a level in 2009 where barely were we at 50, and you can see that the narrow network topic has really become important once again. Not surprisingly, there's a combination of support and skepticism for narrow networks. On the one hand, employers, benefit consultants, health plans have all been actively promoting the idea as a way of ensuring that consumers achieve greater value for their healthcare dollars spent. More importantly, they're also introducing new plan designs and transparency tools to help enable the use of narrow networks. On the other side, you have physicians, hospitals, health systems, consumer groups, all of whom have been raising concerns about issues with regard to access to care and quality that may result from narrow network designs. Narrow networks, for everyone who's been through the various transitions in our healthcare system over the last several decades, are not a new idea. They've been around certainly from the 90s with managed care, and various efforts have occurred on both coasts to try and introduce narrow networks, tiered networks, skinny networks, and other various names, all designed to try and limit or focus access to certain providers. And what we found in our research is that almost uniformly, every approach to narrow network development has looked as described here on the slide. Payers start with an existing list of providers that they have in their network. They look for criteria to try and determine which ones should be included in the narrow network. And not surprisingly, cost ends up becoming a very important factor, but also quality measures are also used. One of the challenges that comes up repeatedly is a lack of appropriate measures beyond some traditional process metrics that allow for true quality to be used as a screening criteria. There may not be adequate metrics, or in other instances, the sample size around certain metrics may be limiting. Once the network's been tiered, then traditional geographic access parameters are used to ensure that there are enough providers in a particular market, and there emerges the narrow network design. From this point onward, contract discussions occur and there are employer feedback, and ultimately you end up with the resulting narrow network design. It's not surprising when you think of that approach why consumers have historically not adopted narrow networks. Firstly, the cost-centric focus, while not the only measure, results in a network that's not necessarily the most consumer-centric in design. Secondly, the benefit designs oftentimes are not aligned with some of the medical management processes that underpin this. And finally, provider backlash, regulatory constraints, and employers who, while in the beginning are supportive of the narrow network construct, ultimately pull out, all make the implementation of narrow networks challenging. So what have we found that is helpful as we think about designing narrow networks for the future? And we'll share some of this, my colleague Nate Holobinko in a minute, on the work we've done to develop narrow networks that we believe will work in the future. The first and foremost parameter is we believe that narrow networks need to be designed around what is desirable to consumers. It's not enough to start with what are the most efficient metrics, what are the costs of the networks. We need to start with what is it that consumers are looking for and what are they willing to trade off as part of their network design. The second important parameter is that medical management processes we have in place need to think about the consumer experience. So, for instance, if we are to move to a narrow network, do narrow networks then come with appropriate improvements in the consumer experience such that prior authorizations, limits on certain elements, co-pays, other structural benefit design elements help reinforce the use of the narrow network and actually make the narrow network experience a more desirable and superior one as opposed to the broad network approach. And then finally, that there is a broad set of support from both individuals and employers for the narrowing construct. And here again, the consumer-centric component becomes critical. Our research has shown that if the employers and employees understand that the networks were designed around their preferences, there's actually a willingness and a desire to support the narrow network construct as it moves forward.
Great. And picking up there, Sanjay, it's nice to be speaking with everyone today. You know, one of the things that we picked up in our approach as we started to look at this topic is to think about the quality of the research that would need to go into this and to start to define the structures that Sanjay was speaking about on the last page. And one of the things that I'm sure is not unfamiliar to anyone on this call is that as an industry, healthcare has been far from consumer-centric, and the types of research methods and approaches that we've used in some of our designs in the past reflect that. And as we endeavored to go down this path, one of the things that we wanted to do was make sure that we were bringing some of the best practices from other industries, particularly the consumer packaged good industry that's been doing this for 30 years with great success, and to bring some of those practices to the table. And as we found when we went down this path, really the quality of the outputs that you get from the exercise are highly correlated to the qualities of the research that you put into it. Before we started to do this ourselves, we sampled what was available both in the industry and marketplace from a common standpoint, and found that a lot of the research that had been done to date kind of scratched the surface in a superficial way in terms of getting at what consumers were looking at. And similarly, even when we started to go down the path ourselves, some of the initial passes that we took at the effort yielded some pretty questionable findings from consumers when we asked them point-blank questions such as, you know, do you like a narrow network, or what would it take for you to switch to a narrow network? Inevitably, when asking the questions in these ways, we got fairly simplistic answers back from consumers that didn't necessarily reflect the way that they actually behaved when they got out into the marketplace. So borrowing back to those consumer research techniques, one of the things that we found was particularly critical was to augment the consumer focus groups, which can be helpful at a high level with conjoint research, with maximum differential research, and then with actual shopping simulator techniques to make sure that consumers are actually behaving in a way that reflects the answers that they're giving. And aside from just understanding their general likes and dislikes, you can actually understand the quantitative implications of the decisions that they're making. So with that, what we did was, over the past several years, we've worked with a series of clients in the healthcare space to help them go down this path. In doing so, we developed a much deeper analysis approach than what had previously been done. So in order to get the granularity that we needed, we typically designed research surveys with very high N sizes, so very high numbers of consumers in the panels, so that we could do deep dives on what they were telling us. Most folks, I'm sure, are aware on this call, and in healthcare, it's not just important to understand what consumers want, but also to understand how those consumers segment, particularly in terms of their utilization of the healthcare system. So matching the right type of profiling criteria, as well as the right type of segmentation criteria up front to understand what type of respondents had what type of health conditions, what was their typical utilization profile before going into the survey also helped anchor our outcomes. But lastly, one of the things that was most important for us, given that the core of this was really to dive deeper on what consumers wanted in terms of their networks and hospitals, was actually to ask the consumer's point of view in terms of what they thought of those hospitals. A lot of the research that had previously been done focused on, useful but commonly available metrics such as HEDIS or STARS outcomes that typically have more of a industry insider or B2B context to them. And instead, when we went down the course of doing our research, we actually asked consumers about specific surveys and asked them to tell us, both in their own words and in terms of what criteria they consider hospitals and primary care physicians to be important or valuable in terms of their care delivery experience and their insurance products. So as we went down the path and did a number of these projects for different clients, some of the results that came out were not particularly surprising, but a lot of these results are actually fairly interesting and even iconoclastic compared to what most of us think about when we think about the network guidelines or the classic rules of the last 20 years. Most interesting is that, whereas we discussed in the previous superficial surveys, it took a lot to get consumers to switch to a narrow network, or consumers at a high level had very bad opinions about narrow networks. When we actually got into specific combinations of narrow networks and specific offerings, we found that consumers could really wrap their brains around the topic and were very readily able to switch to a narrow network in exchange for a price discount. And particularly with the consumer as opposed to an employer audience, as much as 45% of the decision is based on price, and they're very ready to make that trade-off. Interestingly here, another factor that we saw that was surprising even to us was that consumers were far more willing to trade off a PCP than they were to trade off a hospital system. And particularly as we started to get closer to ACA implementation and consumers got savvier thinking about their costs, that factor became even more in the forefront. However, just in contrast to that last point, while most consumers, you could say that consumers in aggregate are a very price-sensitive group, there is a subset, about 30% of consumers, that actually buy insurance almost like a snob bid. And regardless of the specific inclusions in the network, they basically saw a low-price product as equivalent to low quality, and basically showed an inverse utility or an inverse preference for that product. Getting into some of the things we saw around specific hospital inclusions and specific health system inclusions, some of the ways that we in the industry typically think about them are not what consumers think about. As example, safety net systems are not always necessarily a bad thing to consumers. Some of them, particularly in the exchange markets, are held in very high prestige and are seen alongside some of the bigger name academic medical institutions. And then lastly, probably less surprising to folks, is that many of the services that, particularly in the large group market, have become critical or must-have, such as medical management, wellness, gym membership, consumers don't really think about these things in the context of their insurance world. And while they don't mind having them there, they're really not willing to pay anything or trade off anything for them. So diving into a specific example on page 10, one of the things that was most notable to us as we get back to this concept of broad versus narrow is that when you take the word narrow off the table and you actually show consumers specific combinations of hospitals and specific facilities in their area, what consumers actually told us, and you can see by the relative utility here, is it's really not a question of breadth in their mind. Breadth does not equate to quality. It does not equate to price. What people were actually willing to pay the most for was a focused network with a single excellent hospital system, again, excellent as defined by the consumer's mouth, not by a third-party rating, such that they were guaranteed or felt comfortable that they had that excellent system to be able to go to. You can see here that the combinations of good and average hospitals ranked much lower on the relative utility scale. And even more interesting is that when you take that excellent system to add other good systems to it, it actually pulls the utility of that product down for the consumer, again, preferring the more focused but guaranteed higher quality product. Another interesting deep dive one that that's made the news a lot, particularly if folks think about what happened in the Seattle market with some of the controversy over the inclusion of the children's hospital there. It's kind of vernacular in the industry that children's hospitals have to be in network, and it's one of the most important things when people buy their products. But again, what we found is that when you actually dive in and ask people to define in their own world what are the most important hospital systems or health systems, for many folks, having a dedicated children's hospital doesn't necessarily make the cut. They would rather have a single excellent system that they know and keep in high esteem, as opposed to necessarily having a system that's dedicated for children's services alone. And we even deep dove on this topic and found that as you consider both singles and family, while families do consider the children's hospital more important, it doesn't change the overall dynamic, which is that a preponderance or a plurality of the respondents really don't see it as a must-have, and again would prefer to have that single excellent system in their network.
So in conclusion, several takeaways from our research. I think the first one is important around why historically efforts to implement narrow networks haven't been successful. And I think the key takeaway for us is that they weren't ever designed around consumers. And so consumer centricity and really understanding how consumers think about network trade-offs is most critical. The second thing we'd say is that while we've seen narrow networks as part of some of the first generation exchange product offerings, most of them are again designed with a focus on achieving a lower premium. Going forward, however, we do believe that there's an opportunity for the industry to use networks as a means of innovation and redesigning themselves around the attributes that consumers value in their providers. So not only to use them as a vehicle for driving greater cost efficiency, lower premiums, but in fact to increase the satisfaction that consumers have with their products and network offering. The fourth one, which Nate highlighted some of the elements of our research findings, is that there are a number of things that over the last several decades we've built up as long-standing truisms as an industry, that branded is better, that you have to have an academic system in there in order for anyone to buy the product, that pediatric or children's hospitals must be there. All of those elements need to be suspended for a moment as one goes through the research in a particular market. While some of those elements may be true in certain geographies, what's interesting is that we found significant differences in consumer preferences depending upon setting and geography, and those will be important as one thinks about future network design. And then the last thing we'd say in conclusion is that we are at a point where there's an opportunity for our industry to transition to a new paradigm where, firstly, price is a meaningful differentiator for the majority of consumers, but at the same time that we start thinking about products and networks that actually have fewer providers, but actually the ones that are highly valued by consumers as more powerful. Thank you.